Good morning. Good morning. Good morning. Hello. 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 Good morning. My name is Dawn Timiansky. I am on the executive committee of the World Federation, just as Christi and I am the secretary-treasurer, and as you know, Christi is the president. So I'll introduce Christi quickly. She'll introduce herself, but Christi comes to us from Sacramento, California, where it's nice and warm. And Christi is the advanced practice director for both the PAs and the nurse practitioners at UC Davis Hospital, and Christi's specialty is neurovascular surgery. So one thing that Christi won't tell you is she's an absolute phenomenal president. I have no idea. And Christi actually won Nurse of the Year in the US. So how many nurses did you beat out? About 14,000, I think. And she was, I'll give you 1 second, is that her celebration night was the night of the hurricane. So her husband can only take her to Senior Frogs. Now, if you've never been to the United States and you know Senior Frogs, it's, you know, the place where you go and drink shooters and throw your peanuts things on the floor. So they didn't have a good night, or they had a good night. But anyway, Christi won't tell you that story, but she did win Nurse of the Year. So we're happy to have her here.
Thank you so much, Dawn. So we actually laugh a little bit about that story because it was a Category 5 storm coming in, and there were 10,000 nurses in attendance when I was getting this award. And of course, you know, that's overwhelming to be speaking in front of that many people. And on top of that, there's a hurricane coming in. And actually, interestingly, about 9,000 nurses stayed and watched the awards. I mean, it just says something about nursing, right? That they would do that. And then we did go to Senior Frogs that night. And you know, if you've not been there, it's an overwhelmingly gaudy place. That's the only word that I have for it. And so we were sitting at this table trying to have this big celebration because there was no way to get out of Florida at that point. I had waited too late. I couldn't leave. So I was going to have to sit there for the storm. And this was the only restaurant open. There were everybody else had battened down the hatches and said, we're closed, not Senior Frogs. Senior Frogs is in it. They're going to keep going. And everyone in town is eating at Senior Frogs because there's nowhere else open. And above me was this signage that said, I didn't ask you to dance. I said, you look fat in those pants. So we tried to like embrace it and have a good time and have drinks and just say it's fine. But we'll talk today about, I don't know if, oh, there we go. Here's my slides. These are very tiny on my screen, so. Christi, just click down at the bottom. Yep. So I want to talk about medical volunteerism. How many of you have traveled abroad to volunteer? Anybody in the room? Great. So you know it's a very, very different experience than actually working in your own environment. And so I want to talk just for a few minutes about that today because we really want to embrace the idea of people being able to give back and share your knowledge with the world. So I want to tell you a little bit about myself. This is I think of it as my home away from home. This is the UC Davis Medical Center complex, the University of California. It has 6 facilities actually that make up University of California. One of them is located in Sacramento, and it's called University of California, Davis, which is where I work. And I feel like this is my home, just like my home in Sacramento. I also want to talk a little bit about my learning objectives for today. Can you guys hear me well enough? Yeah. I want to review the mission and vision of the World Federation. I also want to talk about key challenges in planning international education and relief. I also want to talk about the preparation required when working with healthcare partners around the world, and then consider opportunities and questions that you should ask when partnering with an international organization. So, just to give you kind of a broad overview of neurological disease, it represents 6.3% of the global burden of disease, and it's expected to increase to 12% by 2030. Stroke is always the number one cause of adult disability, and it reduces the productive years of life, and it's largely preventable. And so that's something that every day in our practice, when we see someone, I always tell my nurse practitioners that work with me, if you see someone that's smoking or has uncontrolled hypertension, you're just waiting for their stroke. And so we absolutely have to counsel them to stop. So one of the most important interventions that I feel like I do as a nurse practitioner is I actually hand them a prescription that says stop smoking. Because I think it's powerful when they actually see it written on a prescription pad that this is something I'm telling you must do. If you don't do this, I'm actually not helping you. Controlling diabetes, making sure that their blood sugar, their hemoglobin A1C is less than 6% or 6.5%. Really, really important. And then 12% of all deaths globally are caused by some sort of neurological disorder. And again, these are largely preventable with education, medication compliance, and lifestyle changes. But we'll talk about some barriers and reasons why that sometimes we don't think about what their barriers, their personal barriers might be. I know that you guys here have a very diverse population with many, many cultures blended. That's true in my area as well. In California, we feel as though we're a melting pot, and we really embrace that. And then unfortunately, you guys probably have heard all the news in California, or actually in the US of our president. And so I'm telling some people that I'm Canadian. And but anyway, that's a different story. So the mission at the WFNN is actually to facilitate interaction among neuroscience nurses across the world. We really believe that you are not just a vessel that to be filled up, that we're actually meant to exchange information so that we can improve the care across the world. We also aid in the exchange and dissemination of knowledge and ideas in the field of neuroscience nursing, and there are a couple different ways we do that. We have teaching videos. We also have a mobile application that I'll talk about a little bit later. We also want to foster the very highest standards in patient care. We want to promote growth in the specialized area of neuroscience nursing. And we want to encourage nursing research to develop the field of neuroscience nursing. We also want to establish neuroscience nursing societies. Sometimes being able to pull together a society of nurses can really advance the field in their area and provide improved care. So when you're thinking about working or volunteering in an area that you're not familiar with, you really should think about evaluating a need or learning more about the need for healthcare in that area. And some of the key things that you'll want to think about is how do people get access to care? So are they coming in on, do they have any public transportation to get them there? Or are they having to walk for miles to get to healthcare facilities? What are the cultural beliefs in the area? How does that differ from westernized medicine? Understanding why someone will not take a tablet. Maybe socially they believe that they need to go to their medicine man first. It's very, very important to understand where they're coming from before you suggest treatments. How many of you have read the book called The Spirit Catches You When You Fall Down? Is anyone in this room? What a powerful story, right? It's about a Hmong child that had severe epilepsy, very, very bad epilepsy. They actually lived in California. They had immigrated from Laos to California, and the parents believed that the seizure disorder was actually a spiritual experience. They did not believe that may or may not be hurting the child. They really didn't understand that. And they also have a bracelet that they put around the child's arm when the child is born. It's very important for them culturally, and they increase that. That's their tie to the earth. And what do we do in the hospital when people arrive? Let's cut that off and put on our band. That's very important to them. This is a huge deal to have that cut off. And so we really need to be thinking that. They also weren't sure about the medications that we were giving the child, and they thought that they could just adjust the doses on their own. They would bring in their medicine man, they would make a sacrifice, and in fact they did that in their home in California and left the head of the cow at the front door, which, as you can imagine, at their apartment building they were not so happy with the head of a cow, but they believed this was very important for this child's health, and they thought they were helping. And so it's very important to understand where people are coming from, because we just kept prescribing medicine without understanding that they really didn't think that these medicines were helping. And in fact, if you offer a prognosis, for example, to say, listen, if we don't control these seizures, it may lead to this child's death, they believe that we are actively poisoning the child. Because how could we possibly know when someone is going to die? They believe that the spirit and the body are very connected. And so being able to offer a prognosis can't possibly be true. And so until we understand those things and take those things into consideration, we're always going to have trouble working with other cultures. We really have to understand where other people are coming from. So the other thing to consider is this a paternalistic society? Is this a maternalistic society? Who do they look to for leadership in medical decision making? So I also want to touch on the global root causes of no care, because they're the same everywhere. So either you can't get to a doctor, you can't afford to get treated, or there are not enough doctors. And these root causes of no care exist globally, even in the US, although we are very, very fortunate to have many, many resources. So this just looks at the shortage. It's a little bit hard to see probably, but you can see that Europe and then the Americas are very, very high in resource. So we have lots and lots of nurses and midwives. We have lots of doctors. We have plenty of hospital beds when compared to some of the other countries. Where you really see people suffering is in Africa and in Southeast Asia, where there are extremely limited resources for care. So how do we combat that? So the way that we should combat that is thinking about how we organize care. How we organize care is largely this pyramidal type structure. It's a pyramid. At the very top, at the very bottom, you have all the people that need care. And then at the very, very top, you have the very, very hard to get to information that specialists know. Then you have senior physicians below that. Then you have nurses that have a lesser amount of information, but good information, and junior physicians. And then you have community healthcare workers. So community healthcare workers might know something like you've sprained your ankle. In the US, we use the term RICE. I don't know if you guys use that. So rest, ice, compression, elevation. So even my children know that. But there are lots and lots of community information, and that's good information. But what we should do in situations where there's barriers or low access to care, we should be thinking about this. We should be thinking about shifting that information so that hard to get to information are surgeons who can perform an external ventricular drain. They should be teaching a general surgeon how to do that in another country. It shouldn't be that we should think of it as well, of course, I went through in the US, it's 7 years of residency, and I can't possibly train that to a general surgeon. Of course you can. You can train that. And the same is true for evacuation of a subdural hematoma. That's a life-changing thing. And so we should be looking at imparting some of these expert skills downward. And the same is true for nursing. We should use nurses to the very top of the scope of practice. Do everything you can to make sure that we optimize them and we teach them everything that they need to know. And then community healthcare workers should be even more knowledgeable so that those basic complaints can be managed by a community health worker. How many of you, Dawn and I were just talking last night about changes in healthcare, what we would consider in the US a disruptive innovation. So the hospitals typically have cared for, it's been very centralized, caring for patients that present with, for example, I have a laceration on my hand, or I have a simple fracture, or I need IV fluid because I'm dehydrated. Now they're decentralizing that. We actually have these mobile vans and these companies that are kind of popping up that have an advanced practice provider on a mobile van that can come to your house. So I just have now a laceration on my hand that I need repaired, and I did that at work. Oh, we'll come to you and we'll fix it. And they are there within 45 minutes. They repair the laceration in your own setting, and that's that. So I don't know if you guys, Don was saying you guys also do that somewhat here, but that's very, very new for us in the US and something that we wouldn't typically do. So this is ENLS, Emergency Neurological Life Support. I'm very, very passionate about outstanding care in the first hour after a neurological emergency. Tomorrow, we're going to talk about emergency neurological life support and hopefully get some of you certified. But this is something that when you look at these types of programs and protocolized care, they've been written in many cases for places that have access to care, right? And so, you know, what if you have intracranial hypertension? One of the first things we think about doing after giving mannitol and trying to stabilize a patient is putting in an external ventricular drain to take off some of that CSF, because we know there's only 3 things in the head. There's the brain, which we can't take out. There's blood, which we probably can't get rid of, and there's CSF. Well, I can get rid of that and try to reduce that intracranial hypertension, but you have no one to put in an EVD, no one qualified, you're stuck. And then what about, we're going to titrate the PaCO2, but I don't have a ventilator. I only have one, and it's in the OR. So we need to think, when we write these protocols, about other countries that are low resourced and figure out ways that we can modify the protocol, because, you know, you may be saying elevate the head of the bed, right? Because that maybe will help in a situation. And we're going to definitely recommend a head CT. Only the closest one is 200 miles away. My brother happens to be, he's on the leadership team at General Electric, and they actually make scanners. And so I was so happy when I took this position with the WFNN. I was thinking, I heard about this under-resourced area in sub-Saharan Africa that only had this one scanner, and the other one was 200 miles away. And I said, maybe I could organize something to help them. And so I worked with General Electric, and we talked about it, and we went through all the options of maybe getting them, getting a CT scanner over there. And at the end of the discussion, we realized they have intermittent electricity. They have absolutely no one to maintain this scanner. The scanner cost to get it there would be as much as, you know, the cost of the scanner itself. And it would probably be out of commission in 6 to 12 months, because absolutely no computer updates have been done on the scanner. You know, so in the end, the infrastructure wasn't there to even support sending them a scanner. So that's another thing to consider. We can send resources, but if they have, let's say we send them a box of supplies, we'll send them all of our external ventricular drain supplies. They don't know how to use it. They have no surgeon to put it in. So always ask yourself, when you're thinking about international relief, am I thinking about this community? Have I done a thorough evaluation of what their needs are and the infrastructure there to continue to support that? So please be aware, and I'll talk about the US model, because there's no question that it's wasteful. I think that we spend more than any country, but yet we do not have the lowest mortality rate. So that will tell you right there that we are overspending in healthcare and that we need to be smarter about how we spend money. So I had a colleague from another country that was visiting. We often are, I'm of course happy to have my colleagues from other countries come and visit and look at the model here in the US. And at first, I didn't realize how much overspending we have. And so you probably have seen this. You have, and maybe or maybe not, you do this. So I work in a university setting, so we have many, many residents that are following a single physician, trying to glean pearls of wisdom about how to take care of a patient. So we have 6 or 7 residents that are following, and we have a patient. These are our isolation carts, patient on isolation. So what does everybody do? Everybody puts on the yellow gown, everybody puts on the gloves, and we all walk in the room to examine the patient. And I didn't even think about it, to be perfectly honest. It didn't occur to me. And my colleague from another country was following me, and as soon as we walked out, she said, "That's ridiculously wasteful." And as soon as she said it, it occurred to me that it was. I said, oh my gosh, of course it is. This is like, I'm throwing away in the trash can for what? I mean, they could have discussed that case outside, and no one could have walked in that room except for the provider that needed to see the patient. And so, it does, when you think about other models of care and when you go to other countries, please be aware. My colleague had no idea that she said it was like Star Wars. When I pushed the button on the bed, that would weigh the patient. So she's like, oh my God, this is like Star Wars. Can you scan them too? I'm like, no. But be aware that they just don't have those resources. When we were in Serbia, Dawn, did you go to Serbia? I can't remember. So you went on the hospital tour, so you know that they had the metal beds. Like, I hadn't seen those since MASH. I was like, oh my gosh. And they had 99 beds for men lined up with glass and the little flow trek, glass bottles, and, ICP control. Here's another pillow. What do you do? So it's a very, very different world, and being aware of what, people have is important. So this is one of my nurse practitioners. I supervise all of advanced practice at UC Davis. We have 174 providers, and this is one of the nurse practitioners that works in the neuro ICU. And so she's smiling, and you can see behind her all of her equipment that she typically uses to manage patients. She's got their ICP, she has all of their waveforms. Everything is there for her to analyze and then carefully dial in that patient to manage them. But this is a little different, right? If I put that same ICU provider in an environment where there's absolutely nothing and there are people sharing beds, you really have to readjust your skill set and think about, what is it that I can do to help people? How can I help people in this environment? This is a maternity ward, semi-private room, right? How many of you have semi-private rooms? We have as many, the most at UC Davis that would be in one room would be 4. I don't know if you guys have the same. So I've never seen anything like that in the States. This is actually an emergency department in India, and there's a colleague of mine in India that has shared some pictures with me. And she was explaining that their situation, and many of the countries have told me this. I actually worked on a study in Russia as well, where there was a payment for your if you wanted your relative to continue to get care, you needed to pay. So such and so has had a stroke, and they're on a ventilator. Grandma's on a ventilator, and today the bill is $800. Would you like to pay, or would you like us to take the ventilator off? That's a tough situation. I can't imagine going through that. It's very, very, very difficult decision to make. So when I think about what we might be able to do, this is actually a teaching model. This is a colleague of mine from the University of Florida. He invented a external ventricular drainage model where they actually have a fake skull, and you actually are able to drill through the skull using his model, and then go in and you actually hit the ventricle, and you're able to navigate. You can see on a screen if your trajectory is correct. And so you'll do all the measurements like you normally would, and then make your burr hole, and then go down and try to hit the ventricle. And you can actually see on a screen whether or not you're close, to help give you that tactical technique of being able to place it. What if we could take his technology to sub-Saharan Africa and train every general surgeon? It would make a difference, even with just being able to reduce pressure in someone and buy them some time until someone that has a little bit more training can get there. When we think about hydrocephalus, this is the #1 reason to present back to a neurosurgery office, hydrocephalus, and it's shunt failure, actually. And so when we think about shunting, I don't know if you guys shunt a lot, but we shunt a lot in the US, and now, I think internationally that doesn't make as much sense. Maybe endoscopic third ventriculostomy, where we actually just create a hole between the two so that it can drain out as much as it can through that hole, is more practical, because shunt failure in sub-Saharan Africa, what are you going to do? We can teach someone how to place a shunt, but that is a constant problem all the time. And so this is a much more practical approach, doing endoscopic third ventriculostomy. And this is actually pretty typical. There's very, very late presentation. In the US, we identify these kids right away. I'm sure you guys do as well. When they're born, that they are going to have difficulty. Maybe they had an intraventricular hemorrhage, a dermal matrix hemorrhage as a neonate, and that's the reason why we're out where we are, or that they had spina bifida. So we know they're going to be needing some type of drainage, but this is much more practical using ETV. So this is my favorite quote because I believe it's true. I think chance favors the prepared mind. If you're far more likely to make some sort of lasting difference, if you know what are the resources in the area, what can they afford, what medicines and equipment are available, what can they maintain? Even if you give them this medicine or equipment, will they be able to use it is another question. What are the roles and how many trained people do they have? And then what motivators are there for people seeking care, and who makes the decisions about healthcare? And then I talked to you about I don't know if I did or not, but there's a child seizing in sub-Saharan Africa, and the mother actually sat there all day long watching the child seize, but she couldn't bring them to the emergency department because she had to wait for her husband to tell her it's okay. And so always be aware that people, there are different societies and they're set up differently, and sometimes there's a decision maker in the home, and it's very important that structure is followed. So we have to then get buy-in from the dad. So when we're talking about using an anticonvulsant on that child, who do we have to get buy-in from? It's not really from the mother, it's the father, because that's who's making all the decisions about healthcare. So when I thought about what we could do as an organization, what could the WFNN do to help the world with neuroscience nursing, it was really to teach people how to do a neurological exam. I felt like if they understood, if they could localize the lesion, if they understood what was wrong with the brain, they had a better chance of actually being effective as nurses, as bedside nurses. And so I learned under a neurologist, and so I believe that a full neurological exam is level of consciousness, mental status, cranial nerves, motor and sensory testing, and gait and balance. I do not think the Glasgow Coma Scale is a complete neurological exam. It is something far smaller than that. It is simply used to detect coma, to understand level of consciousness, and sometimes to predict outcome. And keep in mind, with the Glasgow Coma Scale, the only piece of that predicts outcome is actually the motor score. So the rest of it does not. There are many, many combinations of a GCS of 12, and the motor score is the only one that really predicts outcome. Vital signs, being able to understand why vital signs look the way they do. Do I have a narrowing pulse pressure? What does the patient's blood pressure look like? That's a really important thing when it comes to neurological injury. We know that hypotension is a powerful predictor of poor outcome in the setting of neurological injury. And lowering someone's pressure, not a good idea. And so if we could teach people that, understanding urine output, are they putting out a ton of urine? Is it someone that we think is going into DI because of brain injury? And also just understanding simple things. We probably shouldn't heat them up. Don't pile the blankets on. Fever is not good for the brain. And also head to bed at 30 degrees. It's such a simple intervention, but probably all of you have taken a patient down to the CT scanner, and you've tried to lower the bed, and you've had an ICP that was hovering at 18, and now it's 30, like that. Just because you lowered the head of the bed, and you're like, okay, open the drain. So, just simple things like that. So what we did is we actually created a video, and I'll show you just a piece of the video. But it's translated into 10 different languages. That's my husband, because we have no budget. He said he wants his SAG card. He wants, to get in on the money. Hello, my name is Christi DeLemus, and I am president of the World Federation of Neuroscience Nurses. I want to welcome you to our training course on Neuro Assessment. Neuro Assessment is a critical skill for all nurses who care for neurological patients. It can help you to detect neurologic problems and monitor their progression. The initial assessment should be a comprehensive exam covering the following areas: mental status and level of consciousness, cranial nerves, motor strength, sensation, gait and balance, and reflexes. This initial exam will help to establish a baseline with which to compare all future assessments. This video will teach you how to perform a complete neurologic assessment in 5 easy steps. Let's start with mental status. Level of consciousness. Great. I'm going to ask you to remember some words, and I'd like you to repeat them back to me. Apple, table, penny. So part of that is, and this just shows you how to do visual fields, but we also have information on people that are abnormal, which I thought was really important. Because I think that understanding what's normal is one thing, but being able to pick up what's not, right? So important. That's a 6-nerve palsy.
Now, this is a relatively young patient who had acute onset of third nerve palsy, and when worked up was found to have a dolichoectatic basilar artery. Most likely it was compressing the left third nerve because this patient had pupillary involvement. The pupil is relatively involved on the left side. Going through ductions now, you can see that that left pupil doesn't medially duct, doesn't infraduct well either. You can see that it A-B ducts quite well, 6-nerve function. And supraduction is obviously impaired.
Close your eyes really tight. It's a facial weakness. Don't let me open them. He has weakness of the lower half of his left face, including the orbicularis oculi muscle, but sparing the forehead.
So you got your tongue all the way out. Okay, and then all the way out as far as you can. See the tongue? Get all the way out of your chin. Good. I want you to move your tongue over here to the right side. I want you to move over to the left.
So the entire video focuses on picking up, distinguishing between normal and abnormal findings. And we actually now have a pediatric version as well that we're finalizing and editing. I did make the mistake of saying we have an adult video, and that didn't go over, just so you know, as compared to the pediatric. So now I've said adult neurologic teaching assessment video. So what are some of the things that we really find important? Fostering innovative research. So Peter Vink is actually out of the Netherlands, and he's looking at nociceptive pain and being able to detect pain in patients that are minimally conscious. I think that's such important work. I don't think understand a lot of the times when people are in pain that are minimally conscious. Karen March, actually there's a scholarship, I just want to touch on that one of her colleagues in sub-Saharan Africa that she'd been working with for years and who was instrumental in changing nursing practice in sub-Saharan Africa has recently died of pancreatic cancer. And so we're establishing a scholarship fund in her name. That scholarship money will actually help a nurse from sub-Saharan Africa either attend a meeting with the WFNN or something with the European Association of Neuroscience Nurses or with Neurocritical Care Society so that they can improve the standard of care in sub-Saharan Africa. But she worked also on fighting malaria. And so I want to touch now just on mission-oriented organizations because maybe you've heard of some of these. So Doctors Without Borders, they generally have long-term assignments, but they do have a few short-term assignments that are 6 to 8 weeks. In the spirit of volunteerism, the doctors or healthcare professionals are paid $2,000, and that's US dollars, per month for their care and management there. There's also several international relief organizations, but if you're thinking of working with an international relief organization, there's a few questions that I would ask if I were going to work with them. So is there any payment for mission-specific vaccinations? Number one, there's almost never any payment for your time or for your travel expenses. Those are generally something, it's a mission, so you're responsible for that, or you're responsible for raising funds to help you get there. And who will obtain the required visas and work permits? You don't want to show up and you have no work permit and then you're being sent out of the country because that's not been arranged for you. Who will pay for the flights? Generally, that's something you pay for, but that's a good question to ask. Who's going to arrange and pay for local transportation? I have shown up in one country where I'd not thought of that, and that was a mistake I'm not going to make again. So you definitely don't want to show up, and then you can't read any of the signage anywhere. You have no idea what any of this says, and there's no one that speaks English, and you have no way to get to your next location that you need to be at. Or you find out that is an hour and a half away from where you're at, and you need to take a donkey. Or, that's very, very important to know that information. What are the accommodations in the field? Are you sleeping on the ground? Do you need to be thinking about that? Are you sharing a home with someone that's local? That's very important. Is there paid medical evacuation coverage? So for example, if you develop some really, really bad GI problem associated with eating local food, which can happen because your gut is not colonized with the types of bacteria that they commonly are exposed to, how are you getting it home? That's important to ask. So things that we're working on right now, I talked to you and showed you a little bit about our adult neurological assessment teaching video, but we're also working on a pediatric one. It's almost done. It is translated into 10 different languages. I have copies of it here today, so if someone's really interested in the video. An important question to ask, this was really critical because I didn't know this. Who is aware that some nurses in other countries don't perform a neurological exam? It's just not part of their day. That was a surprise to me. And we had created this teaching video, and I was like horrified to find out, well, our nurses don't do that. We go in and we give medications, but the doctors are the only ones that can perform a neurological exam. And I was like, oh my gosh, well, it's a skill. And it's something that you can learn to do and you can incorporate into your daily practice. But for that country, it's changing everything, right? It's changing how they do business. And so be aware that some countries, when you're thinking about your practice, their practice is not the same as yours. And while I was horrified that I didn't understand that about other nurses in the world, actually one of my colleagues who will speak later today, his name is Neil Cook, and he is from the UK, and he's president of the European Association of Neuroscience Nursing. He came up and patted me on the back, and he said, wow, your video is going to be so impactful. It's going to change everything. And I was like, oh my gosh, that's a good way of looking at it, that it can maybe open the door for the discussion, for a dialogue between their physicians and their nurses. And these are not undereducated nurses. These are nurses with a bachelor's or master's degree. Of course they can perform a neurological exam. It just hasn't been part of their practice. We also have worked on reference sheets to be translated into multiple languages and a mobile application. Oh, I had something there, but it's not there. So upcoming WFN events, we actually have a Congress. Our Congress will be in 2021, and it's in Australia. Beautiful location on the north coast of Australia. So I hope that you're all marking your calendars and planning to attend. But also, I want to give a plug for Neil Cook. The European Association of Neuroscience Nursing will have their meeting in Manchester, and that's actually in the spring. They're still accepting abstracts. And so if you're thinking, oh gosh, I'd love to go to the UK, that's a great thing to think about, to go to Manchester, England for the European Association of Neuroscience Nursing Congress. And I think there's a little flyer in your folders there. Maybe you're thinking one person can't make a difference. I can't go and help internationally because I'm only one person. That's so not true. All of these people were one person, and every last one of them has changed the world. So thank you so much for your time, and I'll be happy to answer a question or two. Any questions? Yes? That's a great question. I don't know how their recruitment strategies work. A lot of organizations really count on word of mouth, that they have someone that's worked with their Madaktari Africa is actually an organization that I became aware of through a colleague, and they do sub-Saharan Africa relief work. They, I think, do shared expense with getting you to the local area and set up everything for you. So they do a lot of that infrastructure work of making sure that you get from the airport to the location and that you have a host family that's going to be helping with your housing and everything, but they don't pay for your cost of flights and things like that. And so that's something that I think usually the smaller organizations are doing word of mouth, because all of their resources largely go into relief efforts. And so, but I think you're right, with more people, if they change their approach a little and put some money into marketing to nurses, then they might have more people to help with the effort. Any other questions? Well, thank you so much for your time. We have a break? Okay, so please feel free to take a stretch break, and then we'll see you back at 10 a.m.